All right, we are going to kick this off. Hopefully everybody can hear me. My name is Liz. I am with Boston Scientific. So we have teamed up with the Pain Institute of Southern Arizona to do some educational webinars when there's new information or procedures available for patients. So thanks for everybody for jumping on here today. I wanted to let you know that your cameras are going to be turned off, as well as your audio will be muted throughout the presentation. So if you do have questions for Dr. Bailey, please type those in the Q&A box down below, and then he will address those at the end of the presentation. So at this time, I'm going to welcome Dr. Bailey from Pain Institute of Southern Arizona, and he's going to begin his presentation. Thanks, Dr. Bailey.
Excellent. Thank you, Liz. I really appreciate it. And appreciate everybody for getting on and participating. Hopefully everyone can hear me okay. So what we're talking about today is new novel treatments for spinal stenosis. And what this is, we're going to talk a little bit about what spinal stenosis is, what that means for you, and what types of symptoms folks get when they have spinal stenosis, and then focus in on alternative treatments that you may not be aware of that have really revolutionized the care of patients with low back pain and spinal stenosis and neurogenic claudication. So first thing, to introduce myself, I'm Chris Bailey. I'm a physician and I'm a diplomate of the American Board of Anesthesiology, and they kind of oversee training for anesthesia providers as well as pain medicine providers, and I'm board certified in both. As we go through here, I'm gonna kind of enlarge this here and we're gonna scroll through it. So there's a big picture of me. I went to medical school in Rochester, Minnesota at the Mayo Clinic School of Medicine. And then I did my residency and fellowship at Mayo Clinic as well. And then moved on working both in Phoenix and then now at the Pain Institute of Southern Arizona in Tucson, Arizona. Our vision statement, we always like to visit this and kind of talk about it because it's an important part of how we practice and how we think about the practice that we have. And through compassion and innovation, we will make a meaningful difference in the lives of individuals and in communities. And we take this really seriously, not only the compassionate end of it, but the innovative end of it. And this is, we're very lucky to be working with Boston Scientific to bring this information to our patients so that you can learn about it in a stress-free environment where you can get some information about this, do some research on your own, and then also talk with us about whether this might be an option for you. The objectives of this presentation are to understand how does spinal stenosis look? We can talk about it, but how does that look to you? Do you have spinal stenosis, and what does that kind of feel like and look like? We're going to define it. And then we're going to talk about the different ways to treat spinal stenosis. The other portion we're going to talk about is Vertiflex, and that's the main kind of subject here, is to talk about Vertiflex and understand how it helps patients, why it helps patients. And then we'll talk about some other procedures that may be able to help patients who might not be candidates for Vertiflex. Because Vertiflex is a fantastic, amazing technological kind of breakthrough, but not everybody's the right patient for it. And the most important thing about taking care of patients is doing the right thing for them at the right time. So, and we're all kind of in the same boat there, wanting to make sure we do the right thing for each of our patients. As we move through here, the question is, what is spinal stenosis, and does this fit kind of the way you feel? So there's some quotes here, it talks about it. Spinal stenosis usually presents with pain while patients are walking or standing. Sometimes they're laying down and they get some of those same symptoms of pain, burning, cramping sensations in the legs. And it's usually relieved by bending over, like a shopping cart, to bend over or over a kitchen countertop, or when sitting down, the pain does improve. We talk about some of these quotes here. They talk about sciatica pain being severe in the legs and the distance that they can't walk not being more than 100 feet or so. Pain medications stop working. Patients can't get around stores or doing the work around the house that they typically would. The pain gets bad. You try injections, which help for a while, but then they stop working or they don't work as well as they had before. Then there's also the symptoms of numbness and tingling in the legs and feet. Those are symptoms of neurogenic claudication, which we'll talk a little bit. the real key is you may feel like you're the only person that has this. You talk with people, they say, oh, I got an injection, or I take a medication, or it just got better over time. This affects millions of people and can age from wear and tear, but also, trauma or injuries and things like that. And I think it's really shocking to look at 14 million Americans having this, and it's really common in people over the age of 60. It's the #1 reason for spinal surgery and can worsen over time. So what are the things you can do? What are the things you can do to try to improve things so you don't have to have this worsening? That can be a daunting thought. So what is lumbar spinal stenosis? We've got a graphic here on the right kind of describing and showing what the back looks like. The lighter portions there are the bones, the discs are in the middle, and those are shock absorbers of the spine. And you can kind of notice if you look at the top disc there, it looks thicker and fuller. And then in the one that's down below where it's got that circle and the magnifying glass there that says disc, it's a little more narrow in the back there, and the nerve root looks inflamed and red. That's a narrowing of that space where the nerve root comes out, which is significant and consistent with spinal stenosis. And that nerve gets pinched while it's in there. And then pain radiates usually from the back into the legs. If you look to the left there, you can see kind of this is if we were cutting the bones in half, kind of like a loaf of bread, basically. On the left there, it shows those loose, healthy, happy nerves in that space behind the disc and the bones there. And the red areas in the illustration there to the right shows the compression that comes from swelling, ligamentous thickening, basically there, and the nerve roots as they get inflamed. So as we move forward, there's different options, and many of you who are already pain medicine patients have probably tried a lot of these different things. Physical therapy is conservative. We've kind of worked through conservative things towards more interventional and more significant kinds of things, to opioid medications, which have multiple downsides. Spinal fusion, surgical on that one end, is kind of the more extreme end of things. Sometimes you have surgery, it doesn't fix things. You've had epidural steroid injections into the low back to reduce inflammation and increase your function and decrease pain. Spinal cord stimulation is an option, and radiofrequency ablation is frequently used for arthritic type pain, which we'll talk about a little bit. As I mentioned, conservative treatments to traditional or severe treatments in terms of stenosis and how it gets more progressively worsened. On the mild end, we treat things with rest, ice, heat, non-steroidal anti-inflammatories like ibuprofen or Tylenol. Epidural steroid injections is what that ESI means. And epidurals are a great treatment, but they don't always work for everyone, and sometimes they decrease in efficacy over time. Opioid medications were originally kind of an early and often used therapeutic option, and we're soon realizing the downside to that, both in terms of decreased efficacy, dependence on medications, and sometimes worsening pain with opioid therapy. On the extreme end for severe stenosis, sometimes that stenosis is bad enough, surgery is the option, and it's the best option to ensure that the stenosis does not worsen, function does not worsen, and fusion might be necessary to stabilize the back. And what Vertiflex does is brings in something in the middle to try to help out with patients with moderate stenosis of the back. And that's where it fits in. So it's in between things like epidural steroid injection and surgery. The Vertiflex procedure is a minimally invasive treatment that can provide effective relief. And what it does is, through a small incision on a same-day outpatient procedure, it provides stability to the back, and stability in that usually when standing up, spinal stenosis worsens through that extension of the back. It puts pressure on those nerve roots, both in the foramen, which is where the nerve root comes out from the back, and then in the central canal. Vertiflex is placed to restrict the movement during extension and keep that foramen and the central canal open and simulate kind of the positioning of the back or the vertebral bodies with the sitting position, which usually gives relief for spinal stenosis. It does not require removal of bone or tissue, so it's not as invasive as a surgery. Recovery is much faster than surgery. Infection and complication risks are very minimal as well and can provide long-term relief. And one of the best things I think about it is that it's reversible. This device can be pulled out without a in-depth intervention, whereas surgery is not reversible. Another thing, since 2016, when this came into play, more than 10,000 patients have had this procedure. So it's been tested in lots of patients and we've been able to see its proven relief. So who qualifies for this? Patients with a diagnosis of moderate lumbar spinal stenosis is the ideal candidate. Patients with persistent leg or buttock or groin pain, that's that radiating symptom that we talked about that is relieved in flexion. And flexion is that forward movement, again, like leaning over a countertop, over a shopping cart, or when sitting. When we talk about function, are you able to sit for 50 minutes or walk for 50 feet without pain? That implies that you have a certain amount of function that you're able to still do. But there are limitations. Maybe it's 100 feet that you walk, and that's when you start noticing, I got to take a break. I've got to sit down, rest for a bit before I go any further. And then another crucial requirement is that you need to have done at least 6 months worth of conservative treatment without relief. Who aren't candidates? And this oftentimes with so many things becomes what kind of controls things. If patients have back pain only without radiating symptoms into the legs, that's probably not the best candidate. If you've got pain in all positions, you sit down and that does not relieve the pain, or leaning forward does not relieve the pain, that might imply that you're not an ideal candidate for this type of procedure. Spinal instability is the next one, and that really relates to the stability or motion of the back when in the extended and flexed positions. Do those bones of the back move forward or backwards? And then scoliosis. Scoliosis is related to kind of the side-to-side curvature of the back. And when we're looking at a target level, that means in between two different vertebral bones is the degree of scoliosis 10 degrees or greater than 10 degrees, excuse me. And then the last thing here is osteoporosis. When patients have osteoporosis, the bone density might give them the higher likelihood of fracture and therefore would not be an ideal candidate for this. So before the procedure, what types of things could someone anticipate? We would do a thorough physical examination. We would take a thorough history of what the patient's history of back pain, surgeries, other interventions, and then also looking into their cardiovascular and pulmonary history as well. We would do some x-rays of the back in flexion and extension, and that's how we look for that instability that we're talking about. A recent lumbar MRI is a must that we want to take a look at, and that would need to be done within the last 12 months. A bone density scan gets used to evaluate for osteoporosis. Then we would also do other lab work, including complete blood counts to look at your hemoglobin levels, as well as your platelet function to make sure that you're a candidate and that you don't have any problems with bleeding. So how was it done? As you'll see on the right, there is a device going in. It's placing the Vertiflex device, which has these wings that come out to fit in between the spinous processes and keep that space open. And that's going to repeat over there. So I'm going to keep talking a little bit, but that small spacer relieves pressure on the nerves by keeping that space open. And if you notice it on the next one, next time that spacer goes in using the placement cannula, watch it here. It kind of opens up the space a little bit. The wings are going to come open and you'll see the spaces between open up a little bit. And that's a crucial part of it. And it's pushed forward for stability up at the lamina, which is that portion of the bone where the spinous process, which are those bones coming out to the end on the right, meet the rest of the bones closer to the spinal canal. The entry space is approximately the size of a dime. So it's a very small entry wound that this is placed. And is meant to basically replicate that flexed position of the back. I'm going to move on to the next slide here. Once patients have had it, what do they typically kind of expect? What happens? In terms of the surgical site, again, infection rates are very low. So there's the safety and the kind of peace of mind that comes with that as well. There'll be a bandage placed on a suture that is closed with stitches. The bandage can be changed daily or as often as it gets wet. We do request that you don't scrub or excessively soak because that'll increase your risk of infection, and then the wound might not heal as well. There are restrictions to activity, and part of that is a weight restriction of what you pick up. We try to reduce the amount of bending or twisting of the spine so that everything kind of heals well. Activities such as swimming, golf, tennis, running, and jogging, those are limited for about 6 weeks. Then the goal, of course, is to increase your activity. That's what we're after here, is to improve your quality of life, your pain, and your activity. We do encourage everyone to walk, and then also have some patience with the recovery area. You can have low back pain for a period of time afterwards that's related to the procedure. It is a minimally invasive procedure, but it's a procedure nonetheless. The muscles are usually not used to being in that position when you're standing up, and your body's going to need a little bit of time to adjust to that new positioning and the lack of pain. So you're going to be experiencing things a little differently for a little while. And that's all normal in the post-procedural period. So what are the advantages of something like this? Vertiflex has multiple advantages. Amongst them is their small skin incision. As I mentioned, the site is about the size of a dime when it goes in. That's substantially different from really any other interventional procedure for the low back like this. Certainly smaller than any surgical incisions. It preserves anatomical structures, meaning it doesn't remove any tissue or bone to work its magic. Minimal operative time. What that means to you is less time under anesthesia. You don't have to have a general anesthetic like you would with surgery. And anytime we can reduce the procedural time, we're reducing infection rates, which I think is a wonderful aspect of it. The procedure is reversible. It requires another incision and then to remove that device as well. And as I mentioned before, a conscious sedation option is an option there. That allows you to breathe on your own during the procedure, but still be made comfortable throughout the procedure using medications to sedate you. What are the risks? This is a procedure like any other. There are risks associated with it. Amongst them, spinous process fractures could occur. And that's that area of the back kind of where it goes through and those wings sit on the sides of to hold it in place. Early on when this was used, the thought was that we needed to open the space up and there was a higher rate of spinous process fractures. Now we realize that it's just as effective by using a smaller spacer and putting it in that place. And that spinous process fracture rate has gone down significantly. So less than 1% can experience this. Early rehospitalization, very small risk of that. And then you look at things like cardiac issues, stroke issues, very low as well. We can't rule that out altogether because, this is a procedure and all patients have a certain risk of that while being held slowly or having a procedure performed, but very, very low. Early wound complications can occur anytime that we do a surgery and we sew something up. There can be some what we call dehiscence where things kind of open up and need to be addressed. Nerve injury can occur, but that's low as well. Bleeding requiring transfusion, again, very low. This is not a procedure that causes a lot of bleeding. Infection rates extremely low as well. Dural tear, what that is, the dura is basically the sac that the spinal fluid sits in. And because of the movement back in there or other injuries, there could be a dural tear. And that might require surgery to repair that dural tear or conservative therapy to take care of that. So here's some cases. Basically, these cases are patients that have presented in some details about it. And some of these, as I describe it, may resonate with you, where you say, that sounds exactly like I'm experiencing. A 71-year-old male presented in April of last year, was diagnosed with spinal stenosis, described as moderate, and then severe foraminal narrowing, again, where that nerve root comes out at L4-5. Patient, when walking for 10 minutes, caused low back and leg pain, got relief while using the grocery cart at the store. Epidural injections were performed, and they had been helpful for several years before, but unfortunately that improvement was not as reliable again last year. So we did a further workup and then proceeded with Vertiflex at that same level where the moderate canal stenosis was at L4-5. The patient had this performed in August of 2020. And as you can see, these are x-rays that we use to place the device. This is on the top portion. It'll show kind of where we're looking down the gun barrel of it. The spinous process is above the device and below it, and the wings kind of hug it on either side, holding it in place. The image down below shows the kind of side view of it with the wings up and down, below and above, and shows, as I look at it, I notice there's an improvement of the spacing between the levels L4 and L5. The patient 2 weeks after the procedure was walking 45 minutes without pain. And 6 weeks later was doing very well in terms of all of the aspects of his pain, including the back and the leg pain. So I think this was a real success story and really kind of the classic pain medicine patient that would qualify for this with moderate stenosis at L4-5. We're going to move on to the second case, and this is an 81-year-old female who presented in 2019 in May to one of our colleagues with right buttock and thigh pain. She had had that for at least 5 years. Again, diagnosed with moderate canal stenosis at L4-5 with foraminal narrowing graded at moderate to severe. And then also at the level above had moderate to severe canal stenosis at L3-4, which is the level just above L4-5. Epidural steroid injections were performed, unfortunately giving only short-term relief. During the evaluation, those films with flexion and extension showed some instability or movement of the bones at the level above. When we talked with the patient, that patient was adamant she did not want spine surgery. Discussed this with the patient, and we performed Vertiflex in August of 2020. Again, if you notice at the top, that is the front to back view, and you can see the wings of the Vertiflex device kind of hugging the sides of the spinous processes. And then down below, it's a little bit lighter in color, but again, going into that space, fully deployed, opening up the space. At her postoperative visit 2 weeks later, she said, I'm doing much better, and was able to stand for a prolonged period of time compared to prior. At her 6-week follow-up, she said her back pain was at least 60% better and did not have any leg pain anymore. So, I mean, these are really impactful stories, I think. These are the results here. As you look to the right, I'll let you read this. Patients are able to have better activity, better quality of life. The pain is improved. And 9 out of 10 patients are satisfied with the procedure. 85% of them that are taking opioid medications decrease their opioid use or aren't using it. 80% or more improvement of their function and reduction of symptoms of 75%. And these are amongst people that participated in this study at 5 years. I think that's really impressive. That is really speaks to the pronounced response that patients have and the long-term relief and benefits that they get. So here's a big list of a lot of different questions, and we'll touch upon them really briefly, but we can always come back to it. You know, in terms of prior treatments, if I've had a laminectomy, RF, spinal cord stimulation, am I still a candidate? Well, it depends. I hate to sound like a lawyer, but it depends. We need to look and see, and every patient is different. We need to look and see what's going on, what surgery was done, what radiofrequency ablation or spinal cord stimulator, and take a look at it. And that's where that one-on-one consultation comes in really handy. It's really important to have that so that we can really focus what we provide for you or anyone else provides for you is custom to what your pain is and what your history is. The procedure, as it says, it's not an overnight stay, same day outpatient procedure. Medicare and Medicaid cover the procedure. And the recovery time, as I mentioned before, we try to limit strenuous activity for about 6 weeks. Will I be able to go through airport security? I had a patient ask me about that today, and it is compatible with imaging, should not set off metal detectors, but you do get a card that just say, hey, I have this medical device, and don't be shocked if you see a little kind of winged spacer back here. Does it restrict my movements? In most patients, it does not restrict movement. It restricts some of the extension of that one area, but it shouldn't restrict you from twisting, turning, bending, lifting, doing things like that after the 6-week period. Does it relieve pain immediately? Again, it depends on each patient. In most cases, patients have some soreness at the incision site, but some patients do have immediate relief. And over the course of the first 6 weeks, that's where we kind of figure out whether the relief or the degree of relief that you get. Other pain management options. You know, what are these things I mentioned before? Spinal cord stimulation, lumbar radiofrequency ablation. There's lots of options, but these are two kind of the main ones that aren't as well known. For spinal cord stimulation, that talks about and treats low back pain and leg pain, and it uses electrical impulses to basically jam the frequencies and the signaling of the back before that pain signal gets to the brain. Most good candidates have chronic pain that's lasted 6 months and hasn't responded to conservative treatments, and has neuropathic pain like constant burning, aching, or pins and needles sensation of the back, legs, arms, or feet. Patients with failed back surgery syndrome, peripheral neuropathy, ischemia, phantom limb pain, or complex regional pain syndrome would be qualify as neuropathic pain syndromes. Patients that have not gotten relief from surgery, medication, nerve blocks, external things like the TENS units or physical therapy would also be good candidates for spinal cord stimulation. Another option we wanted to talk about was lumbar radiofrequency ablation. This is a way to treat pain that is coming from the facet joints, and those are the joints of the back or neck that cause pain, and it's usually related to arthritis. They usually present with low back pain or neck pain, worse in the morning, which improves during the day as activity increases, and it does get worse when standing for prolonged periods of time. This is an outpatient procedure, which typically takes about 15 minutes under sedation and can improve pain for up to 2 years. Indications and references are as follows. The indications, a lot of words in here, kind of talks about a lot of what we've already discussed here, but it's provided here so you can take a look at it. We have some information up here about where to call if you'd like a consultation. Please feel free. There's a number here at 520-345-5100, or email us. And we do have a scheduling team that's available right now if you're interested in finding out more information about this or other options for your low back pain. I've gone over a little bit on my time, but I want to turn it back over to Liz and see if we can answer some questions and help answer maybe some of the specific questions for you.
Great, thanks, Dr. Bailey. A couple of questions that came in. One, I think you somewhat addressed already, but is patients that are they a candidate if they have a neurostimulator that no longer helps?
Absolutely, yeah, and that's a good question because that we have that happen fairly frequently enough to where it merits a conversation about it. That patients will get a spinal cord stimulator, which works great in the trial, works great later on, but then stops working quite as well. And it depends on what it's treating and what's going on in the back. As we mentioned before, patients with prior laminectomy might not qualify for it because we need to have that spinous processed in order to work on there. So patients with failed back surgery syndrome might not be as good a candidate, but it's hard to say without talking or discussing the specifics of your case. That said, nothing beats a consultation where we can talk about all the details of your care, your pain, and your situation. So thanks for asking the question. That was great.
Wonderful. So another question came in. It says, does this work for neck pain?
For neck pain, it's a great question, and it unfortunately is not indicated for neck pain. This is for lumbar spine pain or low back pain at certain levels. So basically from L1 down to L5.
Okay, so another question came in with the patient asking that they can walk a short distance, but they do have pain in their back as well as their hips. They also have arthritis in their hips. Would they be a good candidate for this procedure?
Gotcha. Well, it's, again, that consultation would be crucial because we'd want to look at where is that pain coming from. When people talk about the hips, there's a lot of different areas that people think of with hip pain. Arthritis in the hips presents a certain way. Sometimes low back pain can mimic that. And I think that's a really important component of it because it can radiate around to the back of the hips, the side of the hips, and the front of the hips as well, which can mimic that arthritis of the hips. So I think that's an excellent question. And it would be one that would be really important to take a look at and focus in on the details of your presentation and what your back pain is due to.
Great. The next question is, where is this procedure done?
So the procedure is done in an outpatient facility. When we do it at our surgical center. So it's a surgical center, but it's not an OR in the way you think of that, which means it doesn't require staying in the hospital. You come in, you're seen for 30 minutes beforehand. We do a procedural kind of evaluation, talk with you about the procedure. Then we come back and we do the procedure. Once it's done, we take you to our recovery area where you start to recover, start to feel a little bit more normal after the medication starts to wear off. And then we allow you to basically go home with your driver that day.
Great. Patient asks, if the disc is herniated at multiple levels, is Vertiflex still relevant for our treatment?
Great question. And most patients don't just have that isolated one level of disc herniation or narrowing or spinal stenosis. One of the things we do is we kind of look through things, and it's rated on not only your spinal stenosis, but where your pain is probably coming from. And that is done through physical exam and history. And then depending on where it is, sometimes we can treat one level or two levels at one time to treat that and to see what is the most appropriate course of action. And there's several things that we do to try to diagnose what's the proper level to do that at.
Great. Next question. What if you have multiple discs involved, and how many implants can be placed?
Gotcha. Well, as I mentioned before, there are a certain number of levels that this is where we can place this basically in the lumbar spine, basically 4 spots there. At any one time, we're usually doing 1 to 2 at any one time. And they can be placed, when we place them at adjoining levels. So if we were doing L4-5, we would also do it, L3-4 at that point. Then moving forward, you could do them at the levels above. And, of course, Liz, if I'm speaking out of turn, please correct me.
Nope, it's perfectly correct. Next question. So why would it be reversed and taken out?
Why would it? Well, one of the things would be, if you don't receive any benefit from it, that's one of the main things. Or if you're progressing to surgery, the surgeon can find it just as easy to remove it as us moving in if it turns out you need to have a laminectomy or some other spinal procedure. It's easily removed. There's nothing that's permanent about it. I would say that lack of efficacy would probably be the main reason. Any kind of residual pain or infection would be a reason to take that out as well, although those rates are very low.
Great. Will I be able to change the dressings if I live alone?
It depends on how flexible you are. I would say yes, but somewhat challenging, but it depends on where the placement of it is. If it's in the lower back, it's one of those things that's a little bit easier to do than in the upper portions of the lumbar spine. You know, sometimes those things can be aided by a home health kind of caregiver or something like that can be provided. And some of that is what we can work with you to try to provide the care that you need to make sure that things are taken care of correctly, and working with you, your insurance, and anyone else that's involved in it to make sure that we're giving you the right care and doing the right thing for you. So that's an excellent question.
Next question, can I have an open MRI? I am highly claustrophobic.
Open MRI, I think, is fine. Yes, there are some limitations with open MRI, but I think the technology for it has advanced and is now an excellent option to do it in that way. Yeah.
Great. Can I go back to playing golf without restriction after this procedure?
Again, the main restriction that we have is the immediate 6-week post-procedural time period. We want you to hold off on that, and we don't want you to go out and try to get all John Daly on things too early, because that twisting movement, you know, there's the potential for dislodgement or increased pain, other issues. But after that, you know, the goal, as I mentioned before, of all the things we do is to decrease pain, increase your quality of life and your function. We want you to be out there doing the things that bring you joy.
Great. Next question. This one's worded interesting. So if there is central spinal nerve and spinal processes stenosis, is Vertiflex also a treatment? I'm wondering if it's spinal canal stenosis.
Yeah, and the words get kind of mixed up as we're talking about this. It gets kind of confusing with all the different terminology. And, you know, I'll go out on a limb and kind of say, you know, if this is central canal stenosis, or, you know, sometimes there's another terminology where there is a spinous process that can be touching each other called Bastrup's disease. And when it's touching each other, that becomes a little more challenging and increases the risk of spinous process fracture as we're placing this. But it isn't an absolute contraindication. And in fact, it might, you know, be one of those things that is important to take into consideration during the evaluation.
Great. Is this procedure safe for people on blood thinners?
Well, great question. There's a lot of patients, especially, you know, we look at patients with spinal stenosis are greater than the age of 60. Those are the patients that are most likely to be on a blood thinner as well. And for that, we do ask you to be off of your blood thinner. So that is one of those things that's I would say a relative contraindication, but a pretty firm one, is to make sure that you're off of the blood thinner for an appropriate amount of time before and then after the procedure, usually for a day or two afterwards. And that depends on which blood thinner you're on. And then it depends on what you're being treated for with the blood thinner. And that can be done in consultation with us as well as whomever the prescriber is, whether it's a cardiologist, primary care provider, or a neurologist, or someone else. But that's something we work through with patients all the time. And many of our patients are on blood thinners and then hold it for the procedure.
The next question, is there an incision done with lumbar radiofrequency ablation, or what exactly is that procedure?
Gotcha. So a radiofrequency ablation is not done with an incision. We call it percutaneous, which means that it's basically done with different sized needles or probes. There's a set of injections using a very small needle with local anesthetic, which is used diagnostically to show that that's where the pain is coming from and that it might be a good candidate for the ablation. And then larger bore probes are placed where the nerves grow to supply sensation to the facet joints of the back. They are then heated up and the nerves break down over time over the next 6 to 8 months, or 6 to 8 weeks, excuse me, and that's much longer than what it actually is. So 6 to 8 weeks over time. There's no incisions and it's a very small site where these are performed through.
Okay, next question. Is the Vertiflex only for moderate stenosis?
Great question. So that is really the best indication for it. That said, moderate to severe stenosis is considered, and sometimes severe stenosis can be considered as well, depending on the patient's goals. Are you a candidate for surgery? If not, then we start to be a little bit more, not necessarily flexible, but we look at it in what's best for the patient from that standpoint. So moderate is not the letter of the law, but it's a good guideline to go by. And again, it depends on your presentation and what's going on with you. And we work through patients' different goals, different situations differently. Great question.
So the next patient had bilateral laminectomy at L4-5 as well as L5-S1. Are they still a candidate?
If the area of narrowing or stenosis is at L4-5 or L5-S1, then you probably would not be a candidate in that situation there. If there was narrowing above the levels where there is a spinous process on both sides, you may be a candidate there. But because the procedure kind of requires, if we look here, I'm going to pull up our sample here, and hopefully you can see it. Requires a spinous process on the bottom as well as on top of the space that we're going for. If that is removed, as in the case of a laminectomy, it would be impossible to place this there. So no, that at those levels, you would not be a candidate.
Okay, next question. Does OWCP pay for this? I'm not sure what OWCP is. Maybe.
Those specifics are, it's really tough to say what every insurance, workers' compensation, and other things like that, whether those things would be covered. That's probably best to be done in a consultation, and then we can basically meet with our pre-authorization team to make sure that we will look into that. It varies, and it's really hard to say. So I apologize that I don't mean to make it sound like I'm avoiding the question. I just want to make sure that we devote the right time to your specific presentation.
Next question, how long will I not be able to swim for?
So for that, it depends on the healing of the back. We want to make sure that there's a good amount of healing. I would say if, 6 weeks would probably be on the outside of that, probably sooner than that. Just if things start to heal and do extremely well, it's a case-by-case basis for sure.
Next question, is hip pain during walking a common symptom for lumbar spinal stenosis?
It can be, but it depends on where that hip pain is both coming from and whether it's consistent with the spinal stenosis. Hip pain, like I mentioned earlier, kind of means a lot of things to a lot of different people. Hip pain can be in the front and the groin, can be on the side where there's different bursa or areas of tenderness. And it could be the sacroiliac joint, but it could, in all of those situations, be due to spinal stenosis.
And the next question says, does it work for arachnoiditis? I'm not sure if I'm saying that right.
Gotcha. Yeah, arachnoiditis is basically an inflammatory process of the nerve roots where they kind of clump together, become hyper irritated. I would say arachnoiditis in and of itself is probably not an appropriate indication for Vertiflex, but arachnoiditis due to irritation or pain due to spinal stenosis could be treated. The spinal stenosis could be treated with Vertiflex and could be an excellent treatment. Whether that would necessarily treat the arachnoiditis of it is hard to say based on the limited information I have.
Okay, and it looks like the last question, what type of anesthesia does this procedure require?
Wonderful. So we describe it as a monitored anesthesia care. So it's a little bit deeper than like a deep sedation. And we use different medications. So we'll use a pain medication as well as an amnestic medication to help you feel comfortable, not remember the things that are going on. Again, it's a procedure, there's talk in the area. And then we use a hypnotic to sedate you there. The key features of this is you're breathing on your own. We give you some oxygen to help out if you need it. And you don't have any tubes going down the throat or LMAs or anything like that. So that helps with the safety of things, which is a wonderful factor of it. So monitored anesthesia care or deep sedation are probably the two areas that kind of let you know you're comfortable through it. And most patients are extremely comfortable through the procedure.
Okay, actually, one more question just popped up. There's an existing patient of PISA, and they want to know if you can have everything reviewed from their workup before the consultation visit. So their MRIs, discectomies, x-rays, blood work, etc.
For the majority of things, in terms of that, usually when patients come in, we set it up to find out what they need and what they've already had done in the past. In terms of the lab work, that's usually done prior to the procedure. We don't need to see that to see if you're a candidate necessarily. The MRIs and oftentimes the flexion and extension studies are necessarily ordered unless the patient seems to be a good candidate. Say, for example, if a patient comes in and said, I've had laminectomies and fusions throughout the back, but I want to see if I'm a Vertiflex candidate. It wouldn't make sense to do a flexion and extension study because they're fused throughout the back and would not be a candidate. So why have you undergo the expense of something like that if you don't need it? That said, the evaluation of the consultation is oftentimes to figure out what else needs to be done and are you a candidate? So I think that would be worthwhile. And in most cases, we're taking a look at that stuff and we're going through it with you. Any additional investigations such as x-rays, MRIs, or other studies can be done and then communicated or with you or discussed with you on an ongoing basis afterwards. So hopefully we try to make it as seamless and as convenient as possible for you, even if there are additional studies that need to be performed.
Great. One more question came in. Are there any immunologic side effects from Vertiflex?
Immunologic. So, it's a foreign body, so there could be, in theory, an allergic reaction or a foreign body reaction to it, like anything else. That said, that risk is very low. I'm not aware of any studies that have shown that, but it's a procedure, so that could theoretically happen. In terms of other immunologic, it's a device. It's an inert device, so there will be no other kind of reaction to it, unlike medications or other things like that. So I hope that answers your question.
Perfect. That looks like that is all the questions on here. So I just want to again thank everybody for joining us this evening. I hope you guys all found it informative. A big thank you to Dr. Bailey for taking time out of his day to educate everybody. Very grateful for you. If you have any more questions, you can always call the number on the screen, as well as email the Pain Institute of Southern Arizona. And then this will conclude our meeting. So thanks, everyone. Have a wonderful day.
Excellent. Thanks, everyone. Thank you, Liz.
Bye-bye.